So this talk is important. It's a good place to start when we think about what our goals are and what the unmet needs are. And I'm delighted to have the opportunity to provide some of my insights into this and some pearls. And I recognize that there's a broad audience of very experienced people who are participating in this masterclass. So forgive me if some of this seems more basic, but I also have included more advanced topics for those who are interested. So I'll do my best to cover this broad topic in a comprehensive way over the next 30 minutes. I live in the community where the University of Chicago is, and this is the view I have as I walk to work and the sun is rising over the beautiful Lake Michigan. Our campus is unique in that we have the hospital and the university together. If you look carefully in the distance, you can see the skyline of Chicago, which is 4 miles from here. And our hospital, which is the large building in the background here, is unique as well because we have an inpatient inflammatory bowel disease service, among other things that we do here. And I just share this with you because it would be my great pleasure in the future to welcome any of you who would like to come visit us and to learn from us and for us to learn from you. So I'm extending an invitation. I do have some disclosures, although arguably none of them are directly relevant to what I'm going to present to you. This talk is 100% mine, and I take responsibility for everything I have to say. So the typical features of ulcerative colitis and Crohn's disease are well known to this audience. And the two diseases, ulcerative colitis and Crohn's disease, have been separated for many, many years and have been thought of as sister diseases. They both are characterized by chronic, uncontrolled inflammation, and the location of the disease varies between the two diseases, with, of course, ulcerative colitis confined to the large intestine, and Crohn's disease, by definition, potentially involving any portion of the GI tract. We also recognize some differences in the pathogenesis, as well as the clinical and pathological features of these diseases, as well as the changes that may occur over time due to progression of the diseases and potential complications and coexisting extraintestinal manifestations. You know all of that. The diagnosis of inflammatory bowel disease is based on the gold standard of clinical, radiographic, endoscopic, and importantly, histologic findings. They have to be combined together in the right clinical scenario for us to suspect and to confirm inflammatory bowel disease. I would add one additional feature that is not often emphasized enough, which is the element of time. Sometimes it's not entirely clear what somebody has, and over time it becomes more obvious. There's an old expression, time is on the doctor's side, meaning that if you follow someone long enough, something that may be obscure or difficult to figure out often becomes more obvious. In thinking about this talk, I outlined and identified a number of challenges to the diagnosis of IBD. The first is that it's often confused with other conditions that are more common, functional bowel disorders among them, as well as infections, as you well know, or even food intolerance. And therefore, the diagnosis is often delayed or late, and we are often left with a disease that has already progressed or had complications by the time we make the diagnosis. And then we're always trying to catch up, which is a very challenging point about making the diagnosis of IBD. In addition, there are the diagnostic classification systems that we've used for over 100 years remain imprecise, and there are changes that occur over time that challenge these diagnostic classifications. Unfortunately, one of the biggest limitations, and I think one of the most important priorities for all of us, is that our classification systems don't directly influence medical management, and they need to in the near future. And I'll share some of that with you as we go through this presentation. And lastly, heterogeneity of disease types has confounded our management clinically, as well as, very importantly, our clinical trials. In other words, when we lump everybody together with ulcerative colitis or Crohn's disease and put them in a clinical trial, it's not surprising to see limitations in response and remission rates because we're actually treating multiple different types of diseases. I'm a big fan of the history of IBD, and I want to emphasize to you a couple of points. The concept of what we now call Crohn disease or Crohn's disease, which technically it should be Crohn disease, and you may know that already, actually has been debated because there was a nice report by a man from Scotland, Dial, who first published on chronic interstitial enteritis 20 years before the reports in New York City in the United States. And so while this is now known as Crohn disease, it may be more accurate to start talking more about regional enteritis again as we start breaking these diseases into other characteristics. There's a long story about how Crohn, Ginsburg, and Oppenheimer did not get along, and Ginsburg maintained until the day he died that there were some discrepancies about who did what in their paper, but that's a topic for another talk. But let's give Dial his due credit for contributing to the field in important ways. Now, subsequent to the description that was in the AMA and published in JAMA, there were other descriptions of chronic inflammation, including Harris's report of involvement of the jejunum, other reports of the colon involvement, the small bowel, and the stomach. And therefore, there have been multiple descriptions of this disease, and it evolved over time from the initial descriptions of the fibrostenotic ileum involvement to recognition that it could involve all parts of the disease. And the first published description of what they called Crohn's of the colon is there for you to see in 1959. It was actually of interest that Crohn himself disagreed that what they were seeing in the colon was the same disease that he and his colleagues were involved with in the ileum. So there's been an evolution of what we've done in IBD. And although I'm focusing on the top here, which is our classifications, we've of course had evolution in treatments and evolution in what I call macro management, which includes this masterclass, which is how people have worked together. From the classifications, we've gone from phenotypes to more genetics, to immunological typing, to now some focus on the appropriately environment, including the microbiome. And I'm not going to talk about treatments, that's topics for other days, I know, but we've gone from desperation to evidence-based medicine to disease-modifying therapies to treat to target and altering the natural history of the disease. And lastly, we've gone from different organizations funding research to collaborative efforts to understand worldwide phenomenon. So over time, what we've seen, and the emphasis that I will have in the Crohn's and Colitis Foundation over the next several years while I'm working with them, is about reclassifying these diseases in meaningful ways, focusing on effective, sustainable, and safe therapies that I would add should be affordable and widely accessible, and are organized professional and patient societies and activities to improve access and education. So let's focus now on the diagnosis. The first goal of managing IBD is to obtain a clear and accurate diagnosis. A clear diagnosis of IBD should provide information that first explains the patient's current symptoms and problems. In other words, what you find should adequately add up to explain the way the patient presented and their laboratory abnormalities. It needs to be accurate and withstand the test of time, meaning that if you give someone a diagnosis of IBD, you would like it to be accurate enough that over time it will remain and be clear. Very importantly, you want the diagnosis of IBD to include some element of prognosis so that you can think down the road. We don't like to think of IBD anymore as an acute crisis-based management, but rather a chronic disease that requires planning and proactive intervention. The diagnosis should make a distinction between management decisions that we choose now and those that will affect and change the natural history. And the diagnosis may have implications for others. Although the majority of people with IBD have no family history, we are learning about those in the family that may have an increased risk, and we are developing preventive strategies for higher risk individuals. Very importantly, when you make a diagnosis of IBD, it should include the disease extent and the current disease activity and some element of prognosis. Separating activity and severity is a key goal in identifying the type of IBD and making a clear diagnosis. Activity is how sick the patient is now. Severity has to do with what's likely to happen in the future or what has already happened in the past. And using severity can guide us to monitor more aggressively or change management preemptively so that we don't end up with more complications. The diagnosis of IBD includes making sure that we're ruling out what are called imposters or confusing coexisting problems, thinking about extraintestinal symptoms and signs, not just because we want those to be treated as well, but because I actually believe that when patients have coexisting extraintestinal immune problems, it gives us a clue to the pathogenesis, and reevaluation over time so that you understand what might be evolving before your eyes and as well know whether the disease is being managed properly. This requires ileal colonoscopy with biopsy, the distinction between overlapping functional bowel disorders and those that are due to inflammation, a reliable colleague and expert pathology, evaluation of the small bowel in some way, which may be initially ileoscopy during your colonoscopy, but may require cross-sectional imaging or even capsule endoscopy in some situations. I'm a big fan of working with our colorectal surgeons for an exam under anesthesia to clarify the perianal disease, and I'll talk more about that, and using other clues to clarify diagnosis, including family history, sometimes serologies, and working with our colleagues who are not gastroenterologists like rheumatologists or dermatologists to help us. When we consider the differential diagnosis of IBD, it depends on a variety of factors. In Asia, one of the most important things that you know much more than I is tuberculosis. But other infectious colidities, including, of course, Clostridioides difficile, and now even presenting with a SARS-CoV-2 infection, may present with some symptoms or findings that may look like IBD. Of course, there are a variety of other things that we could get into, but you understand the importance of thinking carefully. If you have an older patient, for example, think about ischemia, whether that might be confused for IBD. And if you have a younger patient, is there something else that may even be congenital or otherwise contributing to the presentation? Diagnosis must include histopathology, and I work with some wonderful pathologists who have taught me the value of understanding chronicity, as well as looking for clues that what might look like IBD may in fact be a monogenic form of inflammation, which I'll talk about in a few more minutes. But you can see clearly here this biopsy from one of my patients with ulcerative colitis and the corresponding crypt architectural distortion with the infiltrate of inflammatory cells. In addition, while we value granulomas, and we now know that granulomas in the presence of Crohn's disease are associated with a worse prognosis, we of course also recognize granulomas may be related to many other things. So you always need to be thinking about those and whether that might be more appropriate for your patient, and thinking carefully about whether this patient might in fact have TB or a fungal infection or actually other immune conditions. There have been some wonderful articles that have tried to distinguish Crohn's disease from intestinal tuberculosis. It's more common in Crohn's to have diarrhea than intestinal TB, for example. And it's more common to have fever in intestinal TB than it is in Crohn's, although both conditions can look like the other. So it's key to rule out tuberculosis in these patients when they present to you. Although it's uncommon for intestinal TB to present with perianal disease, it can do so, as you probably know and have seen. So you still need to think about TB even when there's that perianal manifestation. There have been attempts to describe the endoscopic appearance of either intestinal TB or even Behçet's disease. And although I've tried to learn from my colleagues who say they can tell, I will tell you that we've all been fooled. And obviously biopsies and cultures and serologic testing with quantiferon are necessary in order to distinguish TB from chronic inflammation related to Crohn's disease. Now, there are a number of clues in the history, and I teach this to my fellows every day. We want to know more about what were actually the early symptoms and when did they start prior to diagnosis. And as you know, many patients will have symptoms for years before they get diagnosed. What does the patient mean when they say they're having diarrhea, pain, or bleeding? Because that can be different depending on the patient and the context. And what they say is different than what we say as medical professionals. We should always look for things that wake them up from sleep or unexplained weight loss as clues. In children and adolescents, one of the most important clues is not that the child describes abnormal bowels, but of course that they're not growing or developing appropriately. And that is a very important marker of when the disease onset may have occurred when you look at their growth chart. Although the family history can be a very important clue, remember most people don't have a family history. And even among families where there's one person with Crohn's, about 25% of the time, if it's truly a family history, there may be discordance with the type of IBD presenting to you. Not to mention that I've learned that patients often don't know what their family members have. And lastly, is this really self-limited? So it may look just like IBD, but follow-up is essential. Now on the exam, of course, you know that we're looking for obvious intestinal and abdominal findings. But don't forget the extraintestinal manifestations. I look very carefully at the eyes and the skin, and I do examine the joints as well as the back. I have the patient bend forward and I feel the sacroiliac joints. And you also want to remember to look carefully on their bottom, which you all know, but unfortunately, as you know, our colleagues in primary care and our trainees often don't look, or they look, but they don't know what they're seeing. And this is obviously a patient with a small abscess and a skin tag. Now, there's been an evolving understanding of the phenotypes of IBD, and defining these phenotypes is very important, not only because it clarifies diagnosis, but it does help us with prognosis and understanding natural history. It helps us identify effective therapies or knowing how to deliver those therapies. It helps us avoid some therapies that may be ineffective, like aminosalicylates when there's penetrating or stenotic Crohn's disease. And obviously, phenotypes can help guide research. And I've been arguing that we aren't doing a good job at that. Many of the pharma-sponsored clinical trials focus only on what the regulatory agencies require and not on more clear division of patients into subtypes, which could be really useful for all of us. Ultimately, finding the right phenotypes may lead to some cures, which I'll talk about. Now, the classification of IBD from the 1950s to the present has been divided, as you see in this Venn diagram, where with Crohn's disease, we focus on a majority who have ileal colitis, but recognize that involvement of the colon only is described in about a quarter of patients. And in ulcerative colitis, in adults, 70% are diagnosed with less than pancolitis, but it may extend in 30 to 50% over time. And there's a group right in the middle that we used to call indeterminate. We now call them IBD unclassified, where there's overlapping features and where we're having difficulty figuring out what they have. This plays the most important role when a patient isn't responding to therapy and we're talking about surgical approaches to their management. So we have a clear need to improve our classification systems to help us with diagnosis, to develop a directed approach to identifying causes and cures, and recognizing the heterogeneity of these diseases in ways that are clinically meaningful. So what we have now is the Montreal classification for ulcerative colitis, which divides patients by extent of disease, as you can see here, and doesn't focus on severity or necessarily prognosis. And the Crohn's disease phenotype classifications, which are the Vienna classification and the Montreal classification, which focus on age of diagnosis, location of the disease, and perianal. You'll notice that the Montreal classification added a modifier for perianal disease, specifically in that behavioral type. And that's important because 20% of patients with Crohn's may have perianal disease coexisting with their luminal disease. Now, ulcerative colitis variants that aren't explained by the Montreal classification are important to recognize. If we only focus on the Montreal classification, we're going to be confused and call some patients Crohn's disease when they may have just a variant of UC. This may be the disease in evolution, where it's early onset and hasn't expressed itself fully. It may be the patient with distal disease and a periappendiceal red patch. It may be somebody who has proximal or gastric involvement in kids with ulcerative colitis. Rectal sparing is well described, especially in patients with primary sclerosing cholangitis, a discordant family history, or even discordant serologic markers. The arrow is pointing to the appendiceal orifice. And in a study we did years ago, we showed that the amount of inflammation around the appendix was histologically similar to the amount of inflammation in the distal colon. And we believe this is a variant of ulcerative colitis and shouldn't be called Crohn's. There have been a variety of endoscopic severity indices developed to help us clarify what we're dealing with. And it's important that you understand what these are and adopt them in your practice, not just because you want to be able to communicate with each other about what you're seeing, but you want to communicate back to yourself when you repeat an exam in an individual patient. For Crohn's disease, we have the simplified endoscopic score, and for ulcerative colitis, we have both the Mayo score and the ulcerative colitis endoscopic index of severity. And I'm sure you know that. These should be included on endoscopy reports when possible. Recognizing that, it's actually difficult and it takes time. Look at all the variations in my patients with Crohn's disease. You know how it can look and how variable the endoscopic appearance can be. And when you try to calculate the Crohn's disease endoscopic index of severity, if you're going to do this and you're very busy, which you all are, it takes some time to do it, even if you have an endoscopic reporting system on a computer that enables you to do some of this easier. And on top of that, as some of you know, we're not necessarily treating to complete healing in Crohn's disease like we are thinking about in ulcerative colitis. So as much as I'm here to tell you that you should learn about this, I'm not as convinced that we should all be doing this every time we scope somebody. And of course, the CDEIS doesn't include perianal disease, which has to be carefully documented and should be further clarified with help from our surgeons and additional imaging studies. Ulcerative colitis, while we think of it as being more homogeneous, can also be quite heterogeneous. And you see the variations here in how ulcerative colitis can look. And I know you appreciate this, but when we start talking about using histology as a marker of disease activity or as a target for treatment, which it's not yet, you can also appreciate why biopsies can look pretty patchy under the microscope in some cases of ulcerative colitis. The Mayo score and the ulcerative colitis endoscopic index of severity have some similarities, and they're summarized on this figure, which is from the UC guidelines for the American College of Gastro that we published a couple years ago, and you can appreciate the side-by-side scoring systems. It's actually the UCEIS that's more discriminant for risk of colectomy. And I do need to give credit to a lot of work that's going on in multiple places now on artificial intelligence and how that might help us. This is from our colleague Mamoru Watanabe in Japan and his colleagues, and they've published some very nice work looking at artificial intelligence. And there's some additional work going on in other places around the world, which might simplify and standardize our approach to this, not just from a severity approach, but from a clinical trials approach, and of course, from a diagnostic approach. So stay tuned on that. Charles Bernstein years ago published this very nice study that he says is one of his favorites. And this is about the fact that at the time of diagnosis, the first colonoscopy in ulcerative colitis can appear patchy. And it emphasizes the very important point that you need to biopsy from the areas that look normal as well as those that look inflamed at the time you're making a diagnosis. And actually the histologic involvement of the disease may be more informative in those settings than what you see endoscopically. Interestingly, with some of our new JAK inhibitors, we're seeing histological improvement before we see endoscopic improvement. And there's been some interesting work that suggests that there's a discrepancy in how these appear. So don't forget to biopsy what looks normal when you do those colonoscopies. We also have a score for the late Paul Rootgeerts, who passed away last year, unfortunately, that helps us grade postoperative recurrence. and is being validated in a variety of efforts right now based on how much disease is seen when you scope a patient after they've had surgery with a primary anastomosis and Crohn's. And we've developed an approach to standardize pouchoscopy evaluations. This is the figure and the standard approach we use at the University of Chicago. And in press right now in CGH is the proposed Chicago classification of pouchitis, recognizing all the different phenotypes of pouch inflammation in those who've had a proctocolectomy. So try to be precise and consistent when you're making a diagnosis and in follow-up in your endoscopic reports. Remember, you're describing what you're seeing endoscopically, and therefore you should be using terms like endoscopically quiescent or endoscopically moderately active, and leave the histological assessment to our pathology colleagues, as well as recognizing the clinical assessment, which may be very different. So I want you to be precise when you use your endoscopy reports, not just at the time of diagnosis, but in future as well. On the left is what I do in all of my IBD patients at the time of diagnosis or the first time I'm scoping them, which is I use a biopsy forceps to identify the ileocecal valve so I can get a picture of it on FOSS. And I believe that this is a very helpful way to clarify what the valve looks like, which can be a clue to Crohn's disease or ulcerative colitis, and may also give you a clue to a patient who has backwash ileitis, where the valve may appear patchulous. And I've already shown you the periappendiceal red patch as something to look carefully for when you're doing these exams. Remember too that severe ulcerative colitis can be confused for Crohn's. This patient doesn't have patchy ulcerations. This patient has complete absence of mucosa. You're actually looking at submucosa there. This was a pregnant woman whose Crohn's actually got, whose ulcerative colitis got out of control. She was off therapy at the time of her pregnancy and conception. And of course, cross-sectional imaging is critical. Not only a baseline assessment of small bowel involvement, but that the evaluation may change over time, looking for functional evidence of obstruction with proximal dilation. The cine loops that we can get from MRIs now are quite helpful, and also, of course, to exclude complications. Intriguing to me was a presentation at DDW a couple years ago from China, where they noted that on review of MRIs, up to 20% of patients without physical findings or symptoms of perianal disease had signal intensity in the perianal area. In other words, often we're missing patients who are at risk for perianal Crohn's disease, and it definitely has implications for how we might diagnose or manage them. Now, I hinted at this earlier, and I want to point out to you that we've had some evolution in our understanding of the very early onset or monogenic types of IBD. So remember that it's not always just Crohn's disease because you see inflammation of the small bowel. And there's a listing here of multiple different contributors that can look like Crohn's, but would obviously have very different treatment strategies, including, very importantly, patients who have combined variable immune deficiency, where they are treated with IVIG, and a variety of other specific problems. There's, in fact, a large multi-center consortium looking at very early onset IBD. And if you have a patient in whom you suspect this, you should be looking to their website, which is extremely helpful, veoibd.org. And now we're starting to realize that some of the young adults we're seeing have had this, but were not diagnosed when they were younger. So we now are starting to test adults for some of these genome-wide studies to know if they in fact have these problems. So there'll be more about that. Now, part of diagnosis, as I mentioned, is prognosis, recognizing that ulcerative colitis has variable behaviors and recognizing that Crohn's disease can have variable behaviors. We have recognized that over time, we'd like to impose treatments that modify progression or changes that lead to complications, and knowing who's at risk is very important. So for example, we've learned that ulcerative colitis can progress from being distal involvement. Up to 50% of patients will involve the entire colon. And then of course, we know those patients have a higher risk for surgery, hospitalization, relapse, and neoplasia. And now some more research we're doing shows they have higher risk for rectal involvement that leads to non-compliance of the rectum. Patients who are at higher risk for colectomy and ulcerative colitis are well described, and you should know what they are. They include not just the extent of disease, but patients who have low albumins, those who've had infections or required hospitalizations, or who've needed steroids, as well as those who have deep ulcers when you scope them. Assessment of prognosis is part of the diagnosis when you make it for IBD. And now thinking about IBD as a systemic inflammatory disorder, as I mentioned, this can be a clue to many things. We've now learned that in fact there are shared genetic contributors to not just the intestinal disease, but to multiple extraintestinal manifestations. And we've learned to think carefully about these overlaps. Now, you've been well aware for many years about the serologies that have been described to distinguish Crohn's from ulcerative colitis. And these have been described repeatedly, and there have been other attempts to identify other glycosylation markers related to the difference between Crohn's and UC. But notice what I said at the top in the title here. These are not recommended to make a diagnosis. They are too non-specific. On the other hand, there's some interesting work that's been done that suggests that we can look at P-ANCA, for example, as a predictor of response to infliximab. And you can see here that patients who have a high P-ANCA titer were more likely to less likely to be responsive to infliximab. What about genetics? Can we use that to diagnose IBD or change therapy? Well, not quite yet, despite 20 years of hard work in this area. What we've learned from our colleagues is that there are now almost 300 genetic single nucleotide polymorphisms associated with IBD, and they actually help us decide on extent and location, which is very interesting to us, but it doesn't necessarily help us in management. And remember that something like NOD2, which has the strongest genetic association with Crohn's, is not present in Asians with Crohn's disease. So that's not going to be as helpful. We can look at what we learned about the differences between Europeans and East Asians to know that some of the genetic markers are not the same among groups. So keep this in mind as we start learning more about genetics. And as been mentioned already during the introductory comments, thinking about the microbiome is absolutely important because, of course, we'd like to understand whether that's the main contributor to the rise of IBD we're seeing around the world, and in particular in the Asian countries. Can this be the explanation, or is the microbiome that we're measuring currently just the result of something else? Well, I think there's some great future work that can be done here, but we aren't quite there yet. Right now, it's primarily descriptive. People describing that patients with IBD have much more variability of their microbiome, or they have specific preferential expression of certain organisms and colonies that can be detected. We haven't seen remarkable discoveries yet, although there are a variety of people who are working on bacterial-derived proteins as potential treatments. And we've learned now that although diet is the fastest way to change the microbiota, it may not control the inflammation or do so in a durable way. So there's a lot more for us to learn about, but I'm optimistic about the future. So when thinking about our future considerations for diagnosis of IBD, I think that earlier diagnosis has implications for treatment and will help us get to where we need to be in more patients. How do we make an earlier diagnosis? Well, I'm preaching to the choir, to all of you. You know to think about IBD when a patient is sent to you. But we have to educate our colleagues who are not gastroenterologists or gastrointestinal surgeons so that they are thinking about the diagnosis. We need a clinically meaningful reclassification of IBD that's based on immunological and genetic features. We need to develop immune panels and companion diagnostic biomarkers that will directly influence therapy selection that is underway. I call that the holy grail in IBD management. And we certainly need further clarification of the monogenic forms of IBD because some of these have potential for cure and certainly different treatments, as I've taught you today. And lastly, as I mentioned earlier, we need an identification of at-risk individuals and prevention strategies. I'll summarize with 2 slides. The first one is this interesting work by Marla Dubinsky and Corey Siegel, as well as Lori Siegel, who contributed. That's Corey Siegel's wife, who's an incredible scientist as well. And they describe the combination of genetic, clinical, and immune markers to predict the need for surgery in Crohn's. This was recently acquired and converted into an actual diagnostic test that gives a patient and their provider, their doctor, a curve that tells them what's the risk for this patient with Crohn's disease having surgery in the next 5 years. The important thing about understanding this is to understand how it might influence your choice of treatment, as well as the patient's willingness to use certain therapies. So my final slide is this one. There are many challenges to diagnosis of IBD. The basics are well described, and I've covered them for you today. But remember that it includes separation of activity and severity, understanding the location of the disease as well as the extraintestinal manifestations, having a sense for the prognosis of that patient, and then thinking about a way to characterize each individual patient based on a variety of different markers that might guide us in the future in choices of therapy, prevention of complications, changing the natural history, and ultimately, we would love to have cures for these conditions. This is our IBD Center pre-pandemic, no masks. And on behalf of all of them, I want to say thank you to all of you.
Thank you very much, Professor Rubin, for that fantastic presentation. Question as the moderator. Do you, until we come up with this, I think Steph Targan once mentioned this in some talk a long time ago, that would there be a time when we will have IBD as a IBD 1, 2, 3, 4, 5, 6, as opposed to this very old-fashioned Crohn's disease and ulcerative colitis? Because right now, would you not agree it's pretty inaccurate and somewhat clumsy? Because one of the problems I have is, for example, is when I take part in clinical trials as well, you know, where you have to be one or the other, and the IBD unclassified are not allowed to come in. And I feel these are just such major pitfalls with what's happening at the moment.
Thank you for the question and for the comment. I completely agree with you. In fact, one of the conversations I've had with the Crohn's and Colitis Foundation, they asked me what I thought our big initiative, our moonshot, should be over the next 3 years while I'm chair of their advisory committee. And my belief was that we should focus completely on a meaningful reclassification of IBD that addresses all the things you just said, improves our approach to clinical trials, explains to patients that not all IBD is the same. Imagine when a patient has mild Crohn's, but they go online to read about Crohn's disease, they come across everything, and it's overwhelming. But also because it'll help us develop targeted and appropriate therapies. We're 20 years behind oncology, and I don't think we need to be. I think our cancer colleagues have done a great job, and obviously a lot of research drove that, but we have those things. It's a matter of saying, for example, just simply, I showed you the p-ENC titer predicting response to infliximab. Why don't we go back to that now with the technologies we have and do this in a more predictable and comprehensive way, and take simple things we already know and start breaking them down into meaningful classifications. I completely agree with you, and I hope that came out in some of my comments during the presentation.
Well, we're looking forward to that. So I've got a couple more questions here. So Dr. Partha was asking about the histological yield of small bowel Crohn's disease is low and how to overcome this unmet need. And what's your viewpoint on this?
If I'm understanding correctly, it's the challenge that we face in getting a histological diagnosis when Crohn's disease is present in the mid small bowel or somewhere that's not easily reachable with standard endoscopic approaches. I agree that this is a big challenge. And in some cases where it's not clear what we're treating or where the treatments are not working, we have to rely on either a deep enteroscopy approach, which I recognize isn't always available everywhere, or we have to actually, in rare cases, but we do it, send them for an exploratory laparotomy to actually get a diagnosis. And I think that given that we have expert colleagues who can do a laparoscopic exam if we need them to, that we should rely on that when the diagnosis is unclear. Remember that the differential diagnosis of mid-small bowel stenosis can be multiple other things, including lymphoma. So I don't adhere to the strategy of just throwing steroids and then using other treatments to these patients. I really push to try and get a clear diagnosis. And I think it's a very important topic. I would add to that question that even after you confirm the diagnosis of Crohn's in the mid-small bowel, you have to think about how do you monitor them. We know, for example, that MRI can be helpful, but it's not sensitive enough to pick up all the changes after therapy or progression after surgery. So we need to be thoughtful about ways to do this. There are some evolving and validated serologic measures, something called the Endoscopic Healing Index, published in Gastroenterology last year, which is a combination of 13 molecular markers of mucosal inflammation that you might use, but you have to confirm the diagnosis before you rely on something like that.
Okay, I think maybe we'll ask one more question. So there's this whole thing on the root gut score for postoperative recurrence of Crohn's disease. But so the question is whether or not there's a need for a new score to address things like ileal recurrence, presumably proximal to the anastomosis. I think that has been sort of, bandied about before, and perhaps the role of capsule as well, if I'm not mistaken.
Well, it's a very important question because despite the ubiquitous use of the root GERD score, it hasn't been prospectively validated at the level it needs to be, and that's going on now. And for areas that in the colon, for example, or more proximally, that the score has not been studied appropriately at all. And so there actually is right now an international group trying to develop some consensus statements, which will inform and create a roadmap for future research in this area. I think it's very important to have that, not just to have a score, but rather, of course, to understand progression and recurrence, because the major advance in IBD, in my opinion, has been the role of monitoring at the time you start therapy to make sure it's working, monitoring over time to make sure it continues to work, and monitoring as a proactive approach to disease management. I'm much more in favor of proactive disease monitoring than proactive drug monitoring. I think that the disease monitoring should inform whether you need to assess the drug. So I agree that we need some better ways to do this. And given that we think more and more that IBD is a systemic disease that focuses partially on the gut, recognizing systemic markers that might be helpful would be obviously more convenient and definitely necessary in our field.
Thank you very much. So I think in the interest of time, I think we're going to stop there. I think really we all agree that that was a fantastic lecture. So I really want to thank Professor Rubin for making the time really to give this talk for our first IBD Masterclass. Over